We know that sepsis and septic shock is their huge worldwide problem, so we know the death toll is extremely high. But before we start discussion on hemoperfusion, first of all, I want to go a quick recap on septic shock pathophysiology. First of all, we have pathogens, viruses, bacteria. In case of gram-negative bacteria, all discussion about endotoxin and lipopolysaccharide, which launch the systemic inflammation, which means we have leukocyte activation, huge levels of cytokine release, cytokine storm, and in the end of the day, we've got our distributive shock, endothelial dysfunction, DIC, lysis of the capillary basal membrane, hyperperfusion, capillary leak syndrome, DAMPs, multi-organ dysfunction syndrome associated with immunosuppression. That's the main key points in septic shock pathophysiology. We had a lot of discussion about gram-negative bacteria. Why? Because we know from this landmark paper from Jean-Louis Vincent EPIC-3 study that gram-negative bacteria predominates all over. And it's about 70% in our ICUs, and they're drug resistant. Last year, this epidemiology was published. It's our epidemiology. The same situation, gram-negative drug-resistant bacteria predominates in our ICUs. So we have the pathogen, and while we are waiting for really novel antibiotics with new mechanisms of action, do we able to do something with those pathogens, I mean bacteria, viruses, with hemoperfusion? Yes, we currently have very fancy device, I mean Seraph 100, which is able to eliminate bacteria, viruses directly with heparin-coated beads directly from the blood. And this is similar to those of glycocalyx. So we have no much data about this device, but nevertheless we have a recently published paper from Italy. They looked at cardiac surgery patients with septic shock, with infectious myocarditis, and they tried this device in 13 patients. And they find out that they did better with hemodynamics. And nevertheless, we wait for the results of this European registry for hemoadsorption in sepsis with Seraph filter, led by veteran Premusic from Croatia. Maybe this data will shed some light on this topic. Okay, so. And we know from Survival Sepsis campaign, we need to provide antibiotic ASAP. Okay, but antibiotics somehow promote elimination of LPS, and here you could see E. coli produced LPS treated with moxilactame. And the thing is, the LPS is strongly correlated with our immunosuppression. Here you could look at the macrophage bursted in presence of LPS, and this is also the huge problem. And we have prejudice that their LPS in patients' blood high levels, it's about their gram-negative bacteria in a site and area of inflammation. But this is not the case. We know from Euphrates study that high levels of LPS also related with gram-positive microorganism cultures. It's 1/4 of the patients had their gram-positive blood cultures, and up to 50% had mixed blood cultures. And how come? So their GI might be source of this LPS, and this is nice paper showed their possible translocation from GI. They did a septic model on mice in 2 types of shock, CLP and pneumonia, and showed that tight junctions in GI epithelial layer was damaged, was broken, and facilitate translocation. Okay, so we have a lot of LPS in patient with septic shock. And what we should do with this? we know that LPS is huge molecule, from 30 kilodalton up to 800 kilodaltons. That means it doesn't fit regular filter, RRT filter, I mean, but we have sorption, and it's recently published meta-analysis from China. It's embraced about 30 RCTs, showed that patients with their LPS adsorption had survival benefits in 28-day survival. So it's quite interesting. And another very interesting meta-analysis showed that LPS adsorption probably is better in high-risk mortality subgroup. But how sick? And we know from this nice paper from Japan, they looked at their national registry and in patients with a septic shock, which were treated with LPS adsorption, mostly with PMX. And they redistributed those patients with SOFA scores, and they found that patients with SOFA scores between 7 up to 12 had survival benefits. It's very interesting data, and quite the same data we have from Spain. And this is the same situation that looked retrospectively on 93 patients, and the same data. Patients with SOFA score from 8 up to 13 did better, I mean, from survival perspective. But do we have any clear indication to start LPS adsorption? Probably we have. This is post-hoc analysis from Euphrates, and they looked at the high level of endotoxin measured by EA test. It's from 0.6 up to 0.89, and they did find survival benefits up to 11% at the huge numbers for septic shock patients. And definitely we're waiting for the results of Tigris. John Callum, we know, looking at their patients in this specific range, I mean 0.6 up to 0.89. I have a premonition, probably it will be positive, maybe, and we will have the change of paradigm and septic shock treatment. So we have a lot of discussion about gram-negative bacteria, but what with gram-positive? The lipotechoic acid as a part of outer wall of gram-positive bacteria is not a nice fairy. So it's launched the systemic inflammation the same way as LPS. But the problem is we still have no bedside test for LTA. But my guess, maybe if their LPS adsorption is clinically effective in patients with mixed and gram-positive microorganism cultures, probably it might eliminate an LTA, but it's just assumption. Definitely it should be proven. And we know there are systemic inflammation in septic shock associated with extra levels of cytokines. We know there as higher pro and anti-inflammatory cytokines, they are strongly associated with a high mortality. And we still live in a peak concentration hypothesis, which means we should remove extra cytokines to create gradient for leukocytes to get into the area of inflammation. How could we do it? So for many years we have our hope for hemofiltration, but meta-analysis didn't show any benefits with hemofiltration, probably because there are some cytokines may vary in size. So TNF-alpha, for example, may form trimers. It's up to 50 kilodaltons, which means it doesn't fit regular RRT filter. But we have this quite recently published meta-analysis from Germany, and they didn't find evidence of reduction in mortality with cytokine adsorption, but I do agree with their conclusion. We need adequately designed RCTs in specific medical conditions targeting the right patient. But what the right patient? What are the features of the patient? And I do agree with Professor Molnar that probably this patient should be with lactate level less than 6 millimole per liters, and we do have to start cytokine adsorption within 12 hours from septic shock onset. But we know that cytokine adsorption correlates with our hemodynamic stability. It's very good, so it might be one of the key endpoints for the next searches. And you know about their one interesting device which embrace two features, I mean LPS adsorption and cytokine adsorption, and we did evaluate this device in patients with septic shock, gram-negative septic shock, and there is no difference in mortality, but we found that there less, more MV-free days, SOFA scores were better, and hemodynamics was improved. So, okay, extra cytokines related with our cell and tissue damage. We know this, and we have, with the cell damage, cell-free DNA leaking around. And from this landmark paper from Science 2004, we know that cell-free DNA, I mean neutrophil extracellular traps, is very tricky things. On the one hand, they immobilize bacteria, facilitates phagocytosis and lysis, but on the other hand, they maintain systemic inflammation and immunothrombosis. This is a quite problematic thing. And what could we do with this cell-free DNA? I mean, neutrophil extracellular traps. I know from Andy Aswani did a good homework on the septic shock models on pigs. He tried this device and he did observe that they improved in hemodynamics and kidney function. It's quite good, and definitely we're waiting for the results of this multi-center trial, I mean UCAP, and I have to say that my university also engaged in this multi-center. Maybe we will tell you some indications for this device. So we know that Survival Sepsis Campaign suggests to use antibiotics, and it's very important. Antibiotics is the first line in treatment patients in septic shock, but definitely we know their hemoperfusion distort their concentration of different drugs in patients with septic shock. And this paper was published a few weeks ago, and you could check this table from this paper and adjust your antibiotics and other drugs in patients if you're treating them with different devices for hemaperfusion. Okay, we right now currently evaluating influence effect of hemoadsorption and on antibiotic concentration, and you could see the meropenem and linezolid, they are drastically depleted by hemoperfusion in patients with septic shock, which means we should adjust antibiotics to keep MIC. So what's with the international guidelines? We know the Survival Sepsis Campaign suggest against using polymix with big hemaperfusion and do not give any recommendation about other methods of blood purification. But on the other hand, there are key experts suggest to use hemaperfusion because there is the reason and rationality. So, and I think that new concept, sequential extracorporeal therapy, focuses researchers in features of hemaperfusion, which is able to break this vicious circle and prevent multi-organ dysfunction syndrome in patients with septic shock. And definitely we should be avoiding heterogeneity in patients with septic shock, because it's very crucial to find the right patients for our best results. Since 1931, we know from this landmark paper in Nature by Georges Lemaitre that our entire universe probably born from primal atom with a big bang and still expanding. But currently we don't know nothing, not so much about our entire universe. I mean dark matter, supermassive black holes. But from 1892, when Richard Pfeiffer discovered their LPS endotoxin, we know the source and origin of their universe of septic shock, and we quite a lot knowing currently about matter of septic shock. I mean cytokines, different receptors, and other things. Currently, we are not able to manage entire universe, but day by day, we're getting close to be able to manage the universe of septic shock, even with our extracorporeal blood purification techniques. And in conclusion, septic shock pathophysiology is a very complex problem. Adsorption of pathogens, pumps, dumps, to break the vicious circle. Set is a very important concept, and is set of right direction. Probably with LPS adsorption, we will have quite clear indication very soon, but we should wait. Therapeutic drug monitoring should be used, and hemoperfusion, it's very important. I mean, antibiotics for the first. And definitely we need more RCTs. And currently we're providing the research with hemoperfusion in patients in cardiac surgery undergoing cardiac pulmonary bypass, and maybe we will make our contribution and understanding of effect of their hemoperfusion, because we use extracorporeal, cardiac pulmonary bypass as the model of their systemic inflammation. So this is all my message. Köszönöm. Thank you.